Dr. Emmanuel Akpanabong, welcome to Political Spectrum.
Thank you and good morning.
The elephant in the room. Resident doctors had warned on the 15th of August they would embark on a strike if something was not done to help aid the release of Dr. Popola. And this is 2 weeks or so afterwards, and they have made a good to their threat to embark on a nationwide strike. Just 2 days ago, we saw the rescue of 20 medical students and 7 others who had embarked on a journey to Enugu from University of Maiduguri and Jos. And we saw that rescue. Why has it taken so long for the rescue or the resolution of this case with regards to Dr. Popola?
Well, thank you, my brother. It's unfortunate that we are faced with this situation. First of all, the issue of interrupting medical student doctors is something we don't prescribe, something we don't encourage. But when we look at it, the way it's really unfortunate.
Difficulties there.
Training of resident doctors difficult.
Okay.
And now insecurity has come in. This Dr. Popola is very, very pathetic. Very, very pathetic. 8 months down the drain, the lady has been there in captivity. Now, what the resident doctors are saying is that if the concern for the
we're having some challenges there. I'm sure we'll try to work that out. But laying a background to this, Dr. Popola, working from Kaduna, the National Eye Center, she was actually a breastfeeding mother, and she was kidnapped away from her baby, and along with her husband and her nephew. Her husband has been released, but her nephew and her are still held in captivity. I think we have Dr. Akpanabong back online. Let's try to hear him. Doctor, go ahead, finish your thoughts. You were saying something before we had that light interruption.
Yeah. Good. Yeah, well, I don't know up to where you heard, but I was saying that the case of this lady is very, very pathetic. You've already given the background of her situation as a nursing mother being taken away into captivity. But what we are saying, for a medical doctor to be captured and detained and kept away from the family, from her place of work, preventing her from rendering services to millions of people needing her care, and then the rest of us are going about as if nothing is happening. I think this is why the resident doctors are taking this step. For us, we don't particularly support interrupting services to those who need health care. But what the resident doctors are saying is that why can't we all pause for a while and ask questions? Why? Why is health care delivery so insecure? Why is insecurity so rampant around where health care is being provided? These are the essential questions.
Well, taking you on that, some people would say,
Can you hear me?
Yeah, I can hear you loud and clear. Without sounding insensitive at all, of course, we've been following this story and we've been making sure that it's on the headline. But again, if you look at it across the board, we are having this kidnapping issue in every sector of the country. We have people, in fact, we've had military officers kidnapped and allegedly ransoms paid for their release. We've had this story. So And we've not necessarily seen every the sectors from where these people were kidnapped calling for some kind of cessation of services. So, but I'm wondering, when we saw the 20 students who, thanks God, have been rescued and returned to their families, those students who were heading from University of Maiduguri and Jos to Enugu, it seems as if we saw a lot of movement because there were pressure from everywhere, including from the Minister of Health, and calling the National Security Advisor and the Inspector General of Police to expedite action. And we saw very swift actions. So I'm wondering, is this move more on pushing the hands of the government to take action?
Well, I think you asked the question and you answered the question.
Oh, I did.
we want the pressure to come from everywhere, including you. Yes. Yes. Yes, students are rescued. One person, mathematically, one could say, oh, well, it's an insignificant percentage. But this one person is very important. Or we are saying that even the right, why withdrawing services become relevant is that sometimes when you go to work, particularly in the rural communities, when you go to work, it becomes unsafe for you to even leave your house to the health center, to the hospital that you are working. And therefore, to stay in your house might even be a strategy for at least a short period protection. So here or there, we believe that pressure can help these things get better.
Now, when we take a look at history of kidnapping in Nigeria, we saw that from 2014 with the Chibok girls kidnapping, the kidnap of pupils and students became a strategy for non-state actors to put forward their agenda. And looking at the report, we saw the 20 students kidnapped. In Enugu, there was a doctor that was kidnapped. There was another one that was kidnapped in River State. And then, of course, this one. Are we looking at some kind of a strategy now by these non-state actors to target doctors or people operative in the medical sector? Is that what's playing out, or it's something random?
Well, it looks like that. It looks like that. But I may also extend it to look at the value, the estimated values of these kidnapped people. That if, for instance, a kidnapper can kidnap a governor, can kidnap a minister, the stake could be higher, and it could be financially more beneficial. I don't know whether doctors are rated as important people in society that can call for greater ransoms for them. When they look at students in the private schools, in public schools, and the estimation could be that their parents could be a little bit buoyant to bring out something reasonable. If they pick people in the streets, people who may not have fear of being immodest, not having that high value, it may not be very lucrative for kidnappers. So in that sense, somebody that has been trained in school for more than 6 years, coming out with a certain level of value, and then a kidnapper feels comfortable. If I can kidnap one doctor, 2, 4, there's something great that they have achieved. That's the way I look at it.
Well, let's take another look at this story from the point of view of the impact on people. Yes, while in your opening you actually mentioned that it's embarking on industrial actions like this is a last resort. It's not something you would want to do. Doctors don't want to do that. It's as if their hands are being forced to do it. But I'm looking at the impacts now. Across the country, you have people, millions of people who have been denied services and will be for the next 5 days. Completing the seven-day industrial action. What is in place in the health system to ameliorate the sufferings of millions of people who are being denied medical services because of this action?
Well, whenever they say total, industrial action, withdrawal of service, total, I always kick against it. Sometimes, those of us who run private hospitals, some people could say when public hospitals are on strike, we have more patronage, we benefit. I personally do not enjoy such benefit because the chain of action, there are some cases you don't like to keep in your hospital. You always look forward to the specialist centers, to the tertiary centers. That referral program is interrupted by the strike. And in the process, you can even lose a dear client of yours. So I always encourage some remedial services going on while the action can continue. There should be room for skeletal services here and there so that the impact on the innocent members of the community will not be so much. That's my idea.
Well, let's look at it again now, this time around, the issue of insecurity on the doctors. We've seen that quite a number of doctors have fled Nigeria, some heading to the United Kingdom, others to Canada, US, the Gulf region, and many other parts of the world. And this is one of the issues, apart from also the other issues of inappropriate funding for the health sector, and just the general environment in which doctors do their job in Nigeria. This has led to a flight of so many doctors, and this has impacted the health sector. What should the government, let's just say their minimum, what could the government do at a minimum to forestall this flight of doctors from Nigeria?
Yes, I think we need to open up the conversations. There is no single action that can stop this completely. Let us continue to discuss. Governments, officials of government, the ministers, the directors should not claim they know everything in this regard. Let us listen to the resident doctors. Let us listen to the Committee of Medical Consultants, Association of Private Practitioners. We also have our ideas. Our ideas may not be total, but let us open up avenues for discussions. The other time I presented a paper on the reversal of the traits of medical tourism, and I also addressed this issue of Japa syndromes in that discourse. Some ideas were mooted out. Let these small ideas be picked up, analyzed, and see how implementable they could be. But that's all that we need. These resident doctors have a catalog of things they have said. Particularly the ones that are offensive to them are the ones that somebody who is not in the field there sits down somewhere to make a policy that matters difficult for them. Residency training today, we know that has been so much slowed down in the country that those who can fly outside the country get those things done easily. So these small things are the kind of things we want policymakers to listen. Association of Private Practitioners also have a list of things happening. We talk about National Health Insurance Scheme. More than 20 years ago, certain figures were fixed for capitation, for fee for service, to treat malaria, to treat this. Today, it doesn't make sense. Inflation is not caused overnight. The trend is there. We should be realistic in our reasoning. So with this kind of compassionate understanding, I think things will get better. We don't expect the president of the country, the governor, to overnight solve all the problems. There are some that have simpler step-by-step solutions. That's my idea.
Very recently, the federal government came up with this policy that would restrict the flight of doctors. One of them, of course, would have to do with meeting with countries like the UK and asking them to fund, and some restriction, some bar. Is that the way to go? Banning Nigerian doctors from going abroad, is that effective in solving or mitigating the issue of doctor flight from the country?
It can never be effective. It's a very embarrassing policy to do that. And again, as I said, if you want to churn out a policy as aggressive as that, put it on the table. Let us have conversation on it and see how it works out. It's like ignoring the feelings of the residents in the country and taking up such an idea. The other time, somebody suggested that new young doctors should be denied their certificates, and they are compelled to work for some years before they are given the certificate. In other words, only after then that they can move out. That's a good way of restricting their movement. And these are children that you did not even pay their school fees. You did not even feed them, didn't do anything for them. And of course, there is no restriction going out policy outside the country that you could get. It is a very safe thing to say. So this, to put restrictions and all that sort of things, it doesn't work out. And of course, not many of those countries will accept to listen to such policies.
After all, they are benefiting from it because there are almost 20,000 Nigerian doctors serving in the UK alone. People I know personally. I know so many other doctors personally who are in Canada and the US. I know a whole lot who are in the Gulf. And but if you look at the situation in India, I've raised this issue before, and the Philippines, for instance, the Indians, they are the largest exporters of doctors in the world. At some point, they had millions of doctors across the world, and the Philippines. Can you hear me, Doctor? Can you hear me?
If a policy appears, abilities of the people.
Well, I'm having a conversation with Dr. Akpanabong, and we are looking at particularly the resident doctors' strike, which started yesterday. Of course, the doctors are striking to call to attention the plight of their colleague, Dr. Popola, who was kidnapped since December last year and been in captivity for 8 months. And she's a nursing mother, and she was kidnapped with her husband, who has been released since March, but still held with her is her cousin. We're having this conversation, and we skidded into the general situation of health in the country. Doctor, before we had that interruption, we were trying to talk about the impact of the policy and how foreign governments would implement these new policies. Please finish your thoughts.
Yeah. Yes, I was saying that just running away from the main issues, the push factors, address the pull factors from the receiving countries, is not going to have a lasting effect. Rather, let us look at the internal factors that are pushing our doctors outside and address them. And I believe that conversations, you see, I've been a member of the House of Assembly. I know the competing demands for funds in the appropriation bill. Government, maybe somebody far away from government system would think that government has all the money to do everything. Anything you want government to do, you should do it. It's not like that. We understand. And so, irrespective of the things we list out that government should do to make healthcare better, we are always conscious of the fact that funds are also limited. Let us partake in prioritizing what government is doing. That way we come up with a common stand that can ameliorate the situation. So rushing to make that policy with the international community to further frustrate our children, our professionals, is not the best. But let us do things that are attractive. And I keep saying that people like us have made up our minds to stay here and work. But those of us who stay back, there are certain policies that are clearly inimical to our state, creating discomfort, trying to push us out. And that is the kind of thing we are talking about. If you frustrate me here and you turn to Cameroon, to Ghana, to somewhere to say, if that doctor comes, don't allow him. It's not fair. That's exactly what I'm saying.
Well, I'm even looking at it from the point of view of the recipient countries. Most of them benefit a whole lot because they don't have to spend any money for the training of these doctors, and they are reaping benefits when they apply in their countries. So what about shifting the conversation? Some have put this idea across to holding, like you said, expanding that your envelope of discussant to include benefiting countries. Perhaps they could aid out with some funding. Perhaps that should be the conversation that the government and their policy should be headed in. Doctor, can you hear me? We're having some little challenge there. Of course, he'll be back. But quite some illuminating conversation we're having with Dr. Akpanabong, talking about the government policy that seeks to limit medical practitioners from exiting the country until perhaps they have practiced for a number of years. In their opinion, that would help check the drain of doctors fleeing Nigeria. But I would rather think that we could look at it differently because other countries have had this challenge, and what they did was to turn it to their advantage. So they had a situation in India and the Philippines where a lot of the medical practitioners, doctors in India, while nurses in Philippines, these two countries are the largest exporters of this particular medical personnel, doctors for India and nurses for Philippines. And that's what they did. They found a way to enhance the notice. Okay, we seem to have comparative advantage here. So they improve on their training facilities. So across India, you have so many medical institutions, and across the Philippines, you have them churning out nurses like as if it's some factory. In fact, during the 2020 COVID crisis, when the Philippines threatened to revoke the exit of their doctors and call them all the way from across the world, including the Gulf region, everybody had to call them to take a look at that decision and see how they could change their mind. They were persuaded, and there were considerations given to them. So if these countries have been able to effect policies that rather enhance their comparative advantage by churning out trained medical practitioners and exporting them across the world, maybe we should look at it from that point of view. How many medical facilities do we have, training facilities do we have in Nigeria? Yes, quite a number of universities have a teaching hospital attached to them, and they are aiding in training medical doctors across the country. We also have quite a number of nursing training facilities. But we are yet to have a University of Medicine. Meanwhile, in countries like Ukraine, before they embarked into this conflict with the Russians, they were a good location for Nigerians who sought to be trained in medicine. And because Ukraine had the facilities to train medical doctors in the former Soviet Union. So maybe we should take a look at it and say, apart from trying to curb exits, maybe we should establish one medical university or University of Medicine across the 6 geopolitical zones in the country. That could help. And then fund it properly, see how we can establish some kind of network between these 6 national universities of medicine and the teaching hospitals across the country. I think this would go a long way in enhancing our medical challenge as it is. But of course, like Dr. Kpanabong said, we have a situation in our hand which has to do with our poor economy. And even when our economy was a lot better than this, we never prioritized the issue of health in the country. We would rather spend money on other things, but health was not looked upon as a critical health infrastructure. Again, even this present administration is hell-bent on building a road, a coastal highway from Lagos to Calabar, which will cost 15 trillion naira initial estimates. We don't know what it's going to look like when you put in the present-day value of the naira. Now, if that money was rechanneled to health or a part of it, perhaps we won't be having this conversation. So, Doctor, welcome back. I don't know where you joined or whether you could hear what I was saying.
Yes. Thank you.
We seem to be having a little challenge with the network. But then, I was trying to lay out how okay, go ahead. How would you respond to that?
Zones of the country. Yeah.
Go ahead, doctor. What would you? How would you look at that suggestion?
When you talk about zonal structures where centers of excellence can be located in the various zones.
Yeah, can we?
And I would add that complementarity of services. For instance, if you have maybe University of Port Harcourt Hospital being a center of excellence for kidney treatment, kidney diseases, transplant, and all that. University of Uyo Teaching Hospital, a center for cardiac activities, heart surgeries, and all that. University of Calabar Teaching Hospital with some other part of the body, there is complementarity, where even though for teaching purposes, all these specialties are taught in the university. But when it comes to service delivery, when you are in trouble, you know that if you go to University of Port Harcourt Teaching Hospital, they can take care of this. The other thing takes care of cancer. The other one takes care of kidney. The other one takes care of the heart, and so on. That can be an effective way, to raise the standard of healthcare in the country. At the same time, there are feeder centers, other teaching hospitals, other secondary centers, private hospitals, feeding these apex places. And these apex places, people don't just rush to them until they are referred from these other centers to decongest those places. Like now, I have seen that at the teaching hospital here, people rush down there for malaria, worm treatment, for cough, and by the time you send a very serious patient there, there's no more space. The consultant don't have the time to see. There's no space to admit them, that there is smooth running. And all these ideas have been marketed by the practitioners, the resident doctors, the consultants, private practitioners. But policymakers will sometimes stay far away to say what they want us to swallow. No, I must re-emphasize conversation. We are in trouble. We don't have the resources. Yes, I agree. But these policies, let us be part of the processes, bringing up these policies. That way, you see, I want to admit that there are a lot of patriotic health personnel, patriotic doctors, who are not just thinking of running away, but who want to contribute to the running of the services by way of contributing ideas and rendering their services. And we want this security issue to be addressed urgently so that you don't call a doctor in the night and the first thing he thinks about, am I safe to open the door to go and see the patient? That is the kind of situation we are faced with. And if a doctor refuses to respond to the night call, and you say, oh, these Nigerian doctors, they are not sensitive to the plight of patients, No, you don't do that. In our Hippocratic oath, the pledge, we now emphasize that, look, the health care, the well-being, the health of the doctor is paramount. The doctor must be healthy, must be alive to be able to render these services in a good way. So I agree with you with the analysis you were giving, part of which I couldn't hear because of the bad network. But the summary of it, in my own perspective, is that even the non-doctors should participate in these discussions. The idea is, for instance, when I come to my hospital, I listen to I pick information from the opinion box from my patients. They have useful ideas that help us to run the hospital. Not only the doctors, the nurses that have everything. Healthcare, just like education, is everybody's concern. And we should learn to listen to the stakeholders.
Doctor, thank you so much. Quite illuminating there. But let's shift gears a little bit. I have a personal experience where a friend of mine was admitted to our local Oxford hospital here, the University of Uyo Teaching Hospital. And in fact, we thought he had a stroke, because it seems as if in pursuit of remedies for him, all kinds of tests, all manners of prescriptions were made, only to discover that he had malaria. So I'm picking up on that issue where you raised. He's saying that perhaps we should take a look at the lower level of our three-tier medical system and see how we can energize them so that people don't have to come. The teaching hospital, the tertiary hospital, don't have to be the first hospital of call when people have these emergencies.
That's right.
But then again, right. I'm looking at it from.
It has to be emphasized. Yes.
Go ahead. Go ahead. I'll ask a follow-up question. Go ahead.
Yes. So as I said, that is a very clear thing. You have primary health care, secondary care, tertiary care, and we say that looking at the way the state is structured, the local community, the wards, the local government, state, and so on, everybody cannot run out from the village to the teaching hospital. That may just be one in a state. Every ward should have a health center, primary health center, properly manned by people who can attend to at least those small things, and at least to be able to identify things that they cannot handle and know where to send to. That way, they move to the next general hospital or comprehensive health center, where that everything is not handled there totally. They then move to some other specialized center. So that kind of arrangement makes room for the people at top. Even the clinics we run, the hospital we run, we expect certain things to happen at lower levels before it comes to us. Most patients, when they come, they want to see us. For instance, I, as the medical director, everybody wants to see me. If everybody sees me, the patient, the time to go into the details of even what lower people could have done may make it ineffective. So the same arrangement goes in this referral system. And then that will help to read. So primary health care is key to everything. Like if you have trained midwives, nurses manning the health center with a medical officer visiting or staying, that will reduce the traffic to even the general hospitals and then to teaching hospitals. You see the cost of rendering healthcare will reduce because high cost is particularly due to late presentation of cases. If cases, because of proximity, are attended to, we can relieve a lot of burden.
Doctor, this also, of course, a part of it has to do with the general knowledge. People don't even know this. But then again, there's also this issue of, would I say, a lack of confidence in the quality of the medical personnel at the lower tiers of our health system. This, in a way, has perhaps encouraged patients or people seeking medical help to go to what they would term the best that is available.
Yeah. Yeah, you can't run away from that. Confidence, trust, it's very, very important. Even those that are able to do well, people still think of, I can have a better outside the country. That mentality is still, another person will say, I can have a better deal if I go to the specialist hospital, teaching hospital. Just as I said earlier, they come, the first person they want to see is the medical director of a private hospital, whereas the chain, the protocol, the hierarchy is there. That people, so issue of confidence, you cannot run away from it. But we also have to educate people. For instance, if I have cost to go to that teaching hospital for care, I cannot be just because I know the chief medical director of the teaching hospital. I say he's the person that has to see me. I should learn to know that I have to pick up the card. Some other person will check my vital signs. If there is need for the medical officer on duty to see me, to start the preliminary medical investigations before I even think of seeing the consultant. It's just understanding. And of course, the load is on the leaders to educate people that shared responsibilities would make matters easy. Sometimes if you overwork that person you have trust in, the performance will decline. It will decline, and it may not be as effective as it would have been. So general education is necessary. I must emphasize primary health care is the bedrock. Is the bedrock. I have a hospital here in Uyo. My mother is in the village, and my relatives are there in the village. It cannot be because of small headache they run down to my hospital. There should be some level of care at that stage. Occasionally, I can pop in. There must be. That is why all the health centers, primary health care centers, should be properly equipped in this state.
I would have, but for time, I would have delve into the state of Akwa Ibom State health industry and maybe the Mpox, but we're out of time. But in closing, let's go back to Dr. Popola.
No, well, I can quickly talk about the Akwa Ibom State. Okay.
We are out of time. We are out of time. But in closing, let's get back to Dr. Popola and the National Association of Resident Doctors strike. They've said the strike will end, they will take the full course of 7 days. But that itself is a warning strike. What do you think, in a few minutes, in a few seconds rather, what do you think will happen if 7 days after Dr. Popola had not been released?
Well, you see, in medicine, we very much fear what we call silent killers that don't give warning. Somebody has hypertension, you don't see any sign, no symptoms, all of a sudden it falls down into a stroke and he dies. There was no warning. So if people organize strike and give warning, we should clap hands for such people, that they are very sensitive. It gives you time to reason, to react to why they are going on strike. Sure, anybody that goes on strike should have a reason and should be ready to present those reasons. And it would just be nice, with courtesy, for us to react to those demands they have put across. The things we cannot do, but let's discuss it. To put a deaf ear to it until the expiration of the 7 days, and you now turn to say, these children, these doctors, these people, they are weak here. It's wrong. So warning strike is you don't make rain to fall. If you don't do this to this, I will kidnap people. It will be somehow good. So that is the way I see this warning strike.
That is Dr. Kwanabong, his Chief Medical Director and proprietor of St. Athanasius Hospital in Uyo. He's also a former House member, Akwa Ibom State House of Assembly. Quite a lot of portfolios. He's an official of the PANDEF organization. Dr. Kwanabong, really good to have you on the program today.